All of you for coming out in this windstorm. I've never quite seen anything like this, so I'm glad none of you got blown away and were able to get here. So this is the name of my talk, Bad Science, Bad Medicine, How Flawed Biopsychosocial Studies on ME, Long COVID, and Related Illnesses Harm Patients. And this is me. I'm a senior fellow in public health and journalism at the Center for Global Public Health, School of Public Health at the University of California, Berkeley, which is one of 10 campuses of the University of California. And I put conflicts of interest because I get accused all the time of having conflicts of interest, and some of you may know that I crowdfund to support my academic position, which is very bizarre. And I don't know that anybody else in the US, as far as I know, has a crowdfunded academic salary, but that's what I do. So to the extent that, of course, mostly patients and carers and advocates are supporting my work, that does present issues in terms of what one would call conflicts of interest, so I decided to list those. Okay, so who am I? I was many years as a reporter. I was a full-time reporter at the San Francisco Chronicle. I did a lot of work for the New York Times, although I was never on staff, but for 10 or 15 years I did a lot of health-related stories for them, which was when I first started doing some reporting on what was then being called chronic fatigue syndrome. Around the time of the XMRV situation, when about 10 years ago, I guess in 2010, 2011, when there was some research that suggested that it was connected with a mouse retrovirus. I don't know how many of you remember that or were involved at that point. That turned out to be an issue, but not the case, but that was when I started more getting into this. I first really critiqued the PACE trial, which was the study that was published first in 2011 in The Lancet that purported to prove that cognitive behavior therapy and graded exercise therapy were effective curative treatments for what was again being called chronic fatigue syndrome. And so I thought that was a one-off, but here I am 9 years later still doing this because there still is a need. And so my work basically consists a lot of blogging. I try to, I've done hundreds and hundreds of blogs, but I also, as a journalist, do write for regular news organizations. So some of that is commentary, some of that is, regular stories. And then I also am on social media a lot, unfortunately, which I don't like being on social media. But I also get engaged in writing peer-reviewed commentaries, and also I'm known for writing irritating letters to journal editors pointing out their errors and requesting corrections and clarifications and so on, with some success, but a lot of it is just really to make a point because very often they don't respond or they just ignore the concerns. So this was my initial foray into this whole field. I wrote a 15,000-word expose of the PACE trial, and I published it on a virology blog, which is a site hosted not by me, but by a colleague at Columbia, Vincent Racaniello. He's a well-respected virologist. And so he has since then allowed me to hijack his blog or his site as I want to promote my work or to publish my work. And let's see. Okay, so when we talk about what was called chronic fatigue syndrome, what we're now calling ME-CFS or ME. It's a very complicated nomenclature, so there's probably a cluster of different illnesses, and we don't know exactly what they all are, but for the sake of this talk, mostly probably I will say ME-CFS. But anyway, medically unexplained symptoms is a category that was sort of developed to sort of encompass all the things that people present with that are hard to figure out. So it's very common for people to present in medical, when they go to see the doctor, with unexplained symptoms. And so this term medically unexplained symptoms is a current term, a relatively current term, although it's also, there have been many other terms that have been used. These are some of them: somatic symptom disorder, somatization disorder. Those are more psychiatric terms that have been in the psychiatric literature. Persisting physical symptoms is another term, bodily distress disorder. Many of these were cases of what would formerly have been diagnosed as hysteria or as conversion disorder. Conversion disorder being the psychiatric idea that you're converting your psychological distress into somatic symptoms or physical symptoms. A very common term these days in the last 10, 20 years is functional neurological disorder, which is the updated term for conversion disorder. Many of you know that in Ireland, more recently, this is FND has become a more prominent construct because there is active effort to promote it in Ireland, as it has been very actively promoted in the UK and other countries as a diagnosis that one should give to many people with some of these disorders. And also, we also used to call it hypochondriasis, and now they've changed hypochondriasis, which means you're too anxious about non-existent health things, to they just call it health anxiety to make it sound like, no one wants to be called a hypochondriac, but if you have your anxiety about health, that's sort of considered a little more benign. So as I said, chronic fatigue syndrome, long COVID is now sort of thrown into this, irritable bowel syndrome, fibromyalgia, and basically any other symptoms they can't figure out. One of the problems with the term medically unexplained symptoms is that on its face it's neutral, right? We don't know what is causing these things. That's perfectly appropriate. But the problem is that these people interpret it to mean unexplainable in perpetuity. So what they really mean when they say MUS, or medically unexplained symptoms, is that there is no pathobiological explanation for these things, and it's functional. So functional has become the term of art to essentially mean psychosomatic, or it's not based on or an organic or a problem with the physiological functioning, but it's something going on in your mind only, and brain networks are misfiring and so on. It's not really, so that's one of the ideas about medically unexplained symptoms or functional disorders is that more medical tests only encourage patients to believe in biomedical explanations. In other words, this is a common, paraphrase of what a lot of the people presenting these things think, because they think that if you are encouraging patients to think they have an actual biomedical problem, that it sort of diverts them from the true problem, which is that they have to have psychotherapy or exercise therapy to get better. Doctors have a word for these patients. They're called heartsick patients, because as soon as they walk in, studies show that doctors decide within a few seconds or a few minutes that these patients don't have anything medically treatable. And I'm not minimizing psychiatric problems or psychological problems, as I'm often accused of doing. I'm not minimizing it at all. But if you have a medical problem that's not a psychiatric problem, you need medical care. You don't need psychiatric care, except as perhaps adjunctive or supportive care to help you cope, but not as a curative treatment for your illness. But that's what they generally recommend. So these conditions do, whether you call them MUS, persistent physical symptoms, bodily distress disorder, or whatever term you use, they do present actual difficulties to people investigating them. Basically, these conditions are generally identified by symptoms, right? We identify them not with medical biomarkers, so you can't take a test and decide that you have any of these things. The tests are used to sort of show that they're not other things that have known biomarkers. And so it's hard to determine sometimes who the patients actually are, because anytime you have a category based on symptoms, there's going to be some people in there, especially who don't have it, or you may include people who do have it, who don't have it, and so on. It's complicated to come up with exactly who you're identifying. So that's a real problem. Are these psychological, functional, or are these biomedical disorders? A lot of people say that's a false dichotomy, but the problem is, if you treat something as a psychological or functional disorder, and then you give people psychotherapy, and you say it's not a biomedical disorder, so you don't do the test that might find out what it is, then you're causing problems for the patient. One of the problems is that it's very hard to come up with, because there's no biomarkers, it's hard to figure out sometimes what are the objective measures that could be used in studies. So one of the main problems, and the other problem is that in clinical trials, and basically in just doing treatment, well, in clinical trials, especially when you want to blind people to the intervention, or blind people to what they're getting so you can actually compare, nobody knows what they're getting. That's how you do scientific studies, like with pharmaceuticals. But it's very hard to, you can't really blind graded exercise therapy. You can't really blind cognitive behavior therapy. So that's a real problem. And one of the main issues with all of these studies, or the vast majority of these studies, is that they have a particular design because of some of these complications I talked about. So they're unblinded, or what we call open label studies, and they rely on subjective outcomes solely for their claims of success. So what's the problem? This is study design is really fraught with potential bias and actual bias, because basically what they're doing is they're giving you people, you're getting a treatment that we believe works. You people are getting nothing. You're getting an appointment with the doctor or usual care, just basically nothing. And you know that the other group is getting something. And the other group knows that the something is supposed to help them, and this group knows that the nothing that they're getting is not necessarily supposed to help them. So at the end, in 3 months or 6 months or whatever your endpoint is, when you ask patients, how do you feel? Which is essentially what subjective outcomes do, even though they're all based on questionnaires and so on, but essentially they're asking, how do you feel in whatever domain? How fatigued are you? How's your physical capacity? These are all subjective answers. And those who got the treatment that they suspect or that they're told or that they are led to believe will help them are much more likely to say, gee, I feel better, for any number of reasons than those who didn't get the treatment. Those reasons could be because they want to believe it. They like the therapist, so there's a bond with the therapist, so they want the therapist to feel good. It's expectation bias. There's all sorts of reasons why people are more likely to say that than those who didn't get anything. So when you have modest positive findings in a study with these designs, they're meaningless because you know that that's really likely to happen just from bias alone. So to make expansive claims, as these people often do, based on really minimal findings is just really egregious in terms of science and, as I say, harmful to patients. As I said, it's a challenge to identify useful objective measures. I mean, I acknowledge that's a challenge. And it's a challenge to create legitimate control groups. Again, I don't think you see usual care or treatment as usual, and that's one meeting with a doctor where the other people are getting 25 meetings or 20 meetings or 10 meetings with a therapist. That's not a fair comparison, because basically they're getting a lot of attention and a lot of love and a lot of, jujus from that therapeutic intervention, and the other people are getting nothing. So usually when you want to do a control group, you want to also try to match, like you might do some exercises or something where you're giving people the same attention, but you're not giving them the supposed cognitive behavior therapy that is supposed to be the active part of the intervention. So it is the difficulty creating control groups. However, there are objective outcomes that have been used in some of these studies, which we'll look at. And so these are really objective outcomes that measure physical capacities or physical function. So a 6-minute walking test is a standard test that is used for many illnesses. A step test for fitness, again, getting up and down on a step ladder is a common test. These are all, actigraphy is when you wear a device on your arm or on your ankle or something that physically measures how far you move, how many steps you take or how much you move over the course of a week or a few days. And that should be a measure. If you say you're feeling much better and you're much less fatigued, presumably you're going to be walking more and doing more. But if you find out that, in fact, you say you're much more better, and it turns out you don't move any more than you did at the beginning, then one has to question whether you really are better or if it's just a placebo effect of the intervention. Employment, whether people get back to work or stay at work, whether people are receiving social and welfare benefits is another measure you can use, school attendance. So all these things aren't perfect because they're not measuring the disease directly or the illness directly, they're measuring the impact of the disease on functioning, but in the absence of other measures, they're ones that really should be used. So there's a lot of problematic research strategies that go in terms of producing these, what I would call often fraudulent results. And when I say fraudulent, I want to make it clear that I'm not saying fraudulent in a legal sense. I'm not a lawyer. I can't make legal claims about what's fraudulent in the UK or in Ireland or in the US. I'm using fraudulent in the terms of deliberately deceptive or deliberately manipulative in that sense. So, you know, I've been accused of making false claims that something's fraud. I have never said these are fraud. I say that the findings and the research design is fraudulent, okay? So there's a distinction there. I'm not making a legal claim. But these are all sorts of problems, and when I look at the 3 studies that I picked to look at, we'll see how some of these work. So outcome switching is when you decide you're going to look at X, Y, Z, and then at some point in the study you decide, no, we're going to look at the A, B, C instead. Or you change how you're going to measure something. So you change how you're going to measure something that would appear to improve your results. Claiming success based on secondary outcomes. So most studies generally will have a primary outcome or a couple of primary outcomes. That's what they're most interested in. And then you have a lot of secondary outcomes. If the primary outcome fails, then you can have a lot of secondary outcomes, but you can't claim success of the trial really based on these secondary outcomes. They ignore or dismiss objective findings. So some of the findings that I mentioned, these studies either won't use them, or when they contradict these subjective findings, they just pretend that they don't exist, or they throw them out. They try to sort of make them go away. Interpreting associations as causal in their favored direction. So a lot of studies, there's basically, I'm speaking very crudely, 2 types of studies. Experimental studies, which are clinical trials, where patients are randomized to different categories, and then you can see what happens. And that study design, because is randomized and everybody is, there are differences between people, but when you randomize people and you have enough people, those differences get sorted out through the randomization generally. And so you can make causal inferences from a clinical trial. When you're doing when you're looking at observational studies, the other category is basically you're taking people at what they're doing, and then you take another group who's doing something different or doing another kind of intervention, and then you compare them. But there's many factors that influence what groups people in, what treatments they choose, and so on. And you can't really control for all of those. So in those studies, you only find associations. So this is connected with that. That doesn't mean that this caused that. It may mean that that caused this. It just means that the 2 things are connected. And you cannot make causal statements based on those findings, and yet these people constantly do this. They constantly say this is an observational study, and then in the conclusions they give you causal things, that this caused that or this improved that. You can't say that from these studies unless it's a clinical trial. They misinterpret statistical significance as clinical significance. So, as you know, in studies they do statistics and they decide whether something is statistically significant. In other words, is the difference that we're finding a real effect, and is it significant statistically? Now the problem is you can have a statistically significant benefit, but it's really not clinically beneficial. So basically, if you can move 2 inches more, or if the average group that got the intervention can move 2 inches more than the group that didn't, that may be statistically significant. But obviously being able to move 2 inches more when someone wants to really go back to hiking 5 miles is a completely clinically insignificant finding and doesn't have any benefit for the patients in any practical sense. So when you conflate these 2, it's a real problem. To interpret your clinical, your findings as statistically significant when they're not is a problem. Yeah, so often they pair an article that bad results with a friendly commentary that sort of massages the findings and seems to amplify the results in a way that's favorable to the researchers. That happens a lot. University public relations departments, they don't want to admit that the primary outcome had null findings, so they'll find a way to say, oh, we had success because they're citing some secondary findings and so on. So the universities are often involved in helping to obfuscate what the actual findings are. That's a public relations factor. As we talked about control groups, so often they rely on inadequate control groups. It's an inadequate control group to give a person 1 session with the doctor and somebody else 15 sessions with the doctor. That's just not an appropriate comparison. Or sometimes they just make claims based on no control group at all. They just say, here's the clinic population, and they all benefited from this. Well, if you have a clinic population, even if they improve, but you have no comparison group, you have no idea why they improved. They may have improved from the intervention, but maybe it's just the natural course of the illness, and they all improved anyway. So you can't make any claims, really, except a chronological one that we gave this intervention, and people reported that they felt better. That doesn't have anything to do with whether the intervention itself made them better, if there's no comparison group that you're looking at as well. Okay, so peer reviewing and publishing each other constantly, I call this the circle jerk problem. And so we have, in the US, circle jerk is a metaphor, used as a metaphor for everybody around reinforcing each other, peer reviewing each other, praising each other, and they're all in an insular kind of circle. And so there's no outside scrutiny. They're all doing and approving of each other's work. So I think that we have a massive circle jerk problem in the medical literature in this domain. And it includes the editors, it includes all, NHS, it includes everybody, NHS in the UK. I don't know what your comparable one here is, but it includes everybody at every level that has sort of basically accepted this research based on the prestige of the people doing it. And so we often call this eminence-based medicine. Now, you've heard the phrase evidence-based medicine, so this is really eminence-based medicine. It's really based on the knight, that someone's a knight, someone is a distinguished professor. So there's huge amounts of deference paid to people in positions of authority, much more than is warranted based on the kind of crap studies that they produce. A lot of researchers with undisclosed or disclosed conflicts of interest, and this is in the PACE trial in particular. They had links with disability insurance companies that were not disclosed to patients. So that's a real problem too. Okay, so let's look at PACE trial. Now, how many of you know about the PACE trial? Because I wasn't sure. No? Yes, most of you. So I'm still going to go through it if that's okay. Because this is sort of the bad study par excellence of all this. It's sort of the ground zero, to some degree, of all this horrible research. The PACE trial, I think it's a piece of crap. Simon Wesley thinks it's a thing of beauty. Simon Wesley is Mr. Uber psychiatrist in the UK. Knighted now and on various, high-level panels, and he sort of pioneered the cognitive behavior therapy, graded exercise therapy approach to what he was calling chronic fatigue syndrome back 30 plus years ago, and that's been the standard of care really up until now, except with recent changes. So this was approved in 2003, started in 2005, and this was the first this is the first results published. Were in 2011 in The Lancet, and there were subsequent results published in other journals that were equally ridiculous and bogus, and I would say fraudulent. So this was considered, they called it the definitive study of CBT, cognitive behavior therapy and graded exercise therapy for, again, chronic fatigue syndrome. And again, so look at some of the problems that we already saw. They had some objective measures, but they dismissed them all as irrelevant because they absolutely had pathetic results. So they sort of pretended that these results didn't have any effect on it, didn't matter at all, because they dismissed them as non-objective after all. So their findings of success were solely based on subjective outcomes, and this was an unblinded study, as we know these studies always are. And so, as we said, they make claims based on a flawed study design that basically promotes bias in the results. So this is a problem. The Oxford criteria basically defines chronic fatigue syndrome this is in the 90s, as 6 months of unexplained fatigue, which is a proxy basically for all sorts of undiagnosed depression, anxiety disorders. Fatigue is the most common, along with pain, are among the most common reasons that people go to the doctor and present to the doctor with medical complaints. So if you're going to use a criterion that basically conflates chronic fatigue and a specific clinical entity that we're calling chronic fatigue syndrome, or now more often ME or ME-CFS, you're going to get a real problem, because exercise and psychotherapy are known treatments for chronic fatigue and for depression and for anxiety. If you have depression and anxiety and your fatigue is based on that, then of course you may report some benefits from these interventions. It doesn't mean that has anything to do with ME or ME-CFS as we now understand it. So for example, post-exertional malaise was not required under the Oxford criteria. That's a real problem. So it had 641 participants and 4 trial arms: cognitive behavior therapy, graded exercise therapy, something called adaptive pacing therapy, which was their way to operationalize pacing. They tested pacing, but once you operationalize pacing as a therapy, it's no longer pacing. So they constructed a therapy which they required patients to do as if it was pacing, but it's not. So that was an invalid comparison. And then specialist medical care. I think they called it standard medical care, then they changed it to specialist medical care, or maybe it was the other way around. That's basically your 1 or 2 meetings with your doctor. So all 4 groups got specialist medical care, got SMC, and the other 3 got this added either CBT, GET, or APT. These were the principal investigators. They all are, I have nothing good to say about any of them. And it's based on the unproven theory that all symptoms are due to deconditioning because of patients' dysfunctional cognitions about their illness. So the idea being that patients get sick with a virus or something, they're in bed for a month, or mono or glandular fever, they're in bed for a month, and then they get better and they get out of bed to do something, they feel really tired because they're deconditioned, which happens if you're inactive for a long time. And then they know other people out there are saying, oh my God, there's this thing called ME or chronic fatigue syndrome, and they think, I must have it, so they go back to bed because they're told they might have post-exertional malaise. And so they go back to bed, and then a month later, they get out of bed again, and then again, they feel even worse. And so this is their theory that it's all deconditioning based on their false belief that they have an illness, because they're basically lying in bed all day. You, if you're patients, you're lying in bed all day, and then you get up, and then of course if you're sedentary, you do get dysfunctional circadian rhythms. It disrupts your sleep, it leads to depression, it does lead to sort of, a cycle, a downward vicious cycle, or a vicious downward cycle, as they often say. But it's completely, this is their theory, and it's not really, it's based on their theoretical perceptions. It's not actually based on the reality of what people are going through, because as you all know, through yourselves or family members, patients who actually have this illness have post-exertional malaise. There's a reason why they don't want to do too much. There's a reason why, from their own experience, that they get worse. They have relapses. This is known. It's not a secret. These people think it's all based on that's just deconditioning acting up, and you have to kind of push through it. Now, they don't say that anymore because they understand that there's a problem, but at this time when they did this study, their manuals and so on were very much of the idea that you have to push through this, you need to kind of not pay attention to these temporary fluctuations because they're based on deconditioning and so on. So that's a real problem. They claimed success, that they had 60% improvement and 22% actual full recovery, was in a paper that they published 2 years later. These claims are completely bogus and ridiculous. So here are the expert responses to PACE. One of my colleagues at Columbia, who I interviewed, these are people I interviewed for the study, height of clinical trial amateurism. Now, it's very hard. One of the things that I was able to do when I started looking at this was that patients had all deconstructed the trial. Like, they knew that this was a piece of crap, right? But I was able to come in, because I have an academic background as well as a journalism background, and present everything in kind of a readable way, and also get in my colleagues from Berkeley and other academic institutions to comment on the study. Now, it's very hard to get scientists to say really bad things about a study that they have no involvement with. But in this case, it wasn't that difficult. Why? Because the study was so horrible. My colleagues at Berkeley were shocked at the whole thing. They couldn't believe it. They encouraged me to go continue looking at it. So one of my colleagues, well, actually I didn't quote any of my colleagues in here, but they gave me good responses. Ron Davis at Stanford, a well-known geneticist whose son is very, very severely ill. So he's been researching it, so he said that. Jonathan Edwards at University College London, who's been very active in trying to help patients. He said it's a massive incomprehensibility. I called it a piece of crap, since I'm not much of an academic. I'm an academic, but I'm sort of more like a journalist, and so that's how I talk. Carol Monaghan, who was a Scottish MP, she's lost her seat, called it one of the biggest medical scandals of the 21st century. I personally wrote to her and said, Carol, I think you might want to say it's one of the biggest medical scandals of the new millennium, even though the new millennium was only a few years old at that point. But I think this is good enough. So from the CBT-GET ideological brigades, as I call them, Simon Wesley said it's a thing of beauty. Professor Esther Crawley, University of Bristol, who has since, I think, doesn't seem to be on the scene anymore, she called it a great, great trial. When I started my thing, Queen Mary University of London, which was the home university of Peter White, the lead author, basically accused me of causing online abuse and reputational damage. I was hoping to cause reputational damage. I certainly wasn't planning to cause online abuse. So I was appreciative that they said that. I wasn't happy that they said that because I don't think I can be blamed for anything that comes their way based on an accurate accounting of the terrible things they did in the study. So here are the reasons for concern. Can everybody hear me, or am I talking too fast? Or I have a lot of slides to get through, so I kind of, and is it all understandable?
Yeah.
Okay.
Sorry, it's okay, I'll take pictures because my son isn't here.
Oh, yeah, okay. I think they're recording this one too, so there'll be a record of it, but feel free. So these are some of the, I wrote 15,000 words about this trial, but I couldn't even cover everything that was wrong with it, okay? So there's a lot wrong with it, but these are some principal ones. We talked about outcome switching. Lack of legitimate informed consent is a problem. They published newsletters during the trial, and one of the newsletters during the trial had testimonials from patients about how great they did in the trial. You can't do this. You just can't do this. It's ridiculous. They rejected all their objective outcomes as not objective after all because they failed to support the subjective findings. And well, these were the fact that it was a problematic study design and the use of the Oxford criteria. This is bad science, but it's not clear that these warrant retraction. These things really warrant corrections and retraction. The Oxford criteria was a published criteria, so it was okay to use it even if it's bad. And it's not okay to use it, but it's legitimate to use it from a scientific perspective. And the study design, as I said, I wish none of these studies were done that relied solely on subjective outcomes if they're open label, but they're an accepted form, so that's a problem. So here's the outcome switching in PACE. I'm going to talk about just one of them because it's so striking. Every change they made their outcomes weaker, or made it easier for them to report benefits because they lowered the thresholds for success. So this is an example. The SF-36 is a well-known scale measuring physical function. It's like a set of questions, and you answer yes. You answer, can you climb stairs? I'm just paraphrasing here. I don't know exactly. Not exactly. Can you lift things? Can you climb stairs? It's all about how your physical capacity. And you answer each one, and the scale is 0 to 100. So basically, most people will, if they're reasonably healthy, even if they have some disability, will score 80, 85, 90, 100, quite high on this scale. So initially, they chose to get into the trial. To demonstrate disability, you have to score 65 or less on this scale at trial entry at baseline. Initially, in their protocol, which they published before they didn't publish it before the trial, but they wrote it before the trial, they said 85 was recovery for physical function. And they also said 75 was improvement for physical function, and 85 was recovery for physical function. But they changed this to what they called they changed this threshold to 60 because they would get better results. They found a statistical manipulation to do, which is too complicated to go into, but this statistical manipulation was fraudulent on its face. And they came up with a threshold for 60. So basically what they said was you could be recovered, you could enter the trial with a score on this of 65, you could get worse and have a score of 60, but you would still be considered recovered for physical function. Does this make any sense to anybody? It's like you have an HIV test and you can be positive and negative at the same time on the HIV test. You cannot be disabled and recovered simultaneously on a measure in a study. It is absolute nonsense. It's just ridiculous because it's nonsensical. It doesn't, if you get worse on it, you got worse. You can't, how can you be disabled and then get worse and be counted as recovered? But that's what they did. It's mind-boggling, and it's such a ridiculous thing that I think it's hard for people to actually take in, because when I would explain this to people, they'd look at me like I was crazy. You must be misunderstanding. But no, if you actually look at the trial, that's what they did. So if they were, when patients got through Freedom of Information requests, they got the actual data, and they found out that 13% of the participants were already recovered for physical function at baseline. So this basically invalidates, from my perspective, the entire trial. They shouldn't have been in the trial in the first place. It shows evidence of bad faith, because they knew that they must have known this was what they were doing, that they had these people in this category. You can't do this. It makes the trial fraudulent on its face. This was not disclosed in any of the published papers. This is research misconduct of an egregious degree. You cannot have findings that affect how the study would be interpreted, and then just decide to omit them completely from your study. Obviously, if people reading the study knew that 13% were recovered on this measure, that would raise a lot of questions about the findings, but they failed to let anybody know. And then they didn't want to give any of the data. So there were other outcome switching in the trial, multiple examples. They all weakened every change they made was to be able to report, or had the effect of allowing them to report better results. So they gave some answers that are ridiculous. They said we changed outcome measures before seeing the results, so they were pre-specified. This is nonsense, because it might work if it was actually a pharmaceutical trial, but in an open label study with subjective outcomes, you pretty much should be able to tell during the trial whether patients are getting better or not, because there's nothing secret going on. You see what's happening. So you know you're having problematic results if you're smart. And so this is a non-answer. As I say, we decided the original measures were too stringent. They spent years writing a protocol. How can you decide, after you spend years writing a protocol and it's approved and you get funding based on that protocol, afterwards that your measures were too stringent? This is obviously an admission that all the changes you made were to get better results. I mean, it's a flat-out admission that that's what they did.
Can I ask a question?
Yeah.
Did they just base it on basically the fatigue part of ME? Because that's what it sounds like. They just looked at if you were fatigued enough,
Well,
get up and down, like they didn't base on.
Well, no, I
And
mean,
just-
this was a physical function scale, so they had a separate fatigue scale, but the fatigue scale had the same problems. So they viewed chronic fatigue syndrome as a problem just of bad fatigue. So yes, they did, but this measure was not a fatigue measure. But yes, the overall conception of chronic fatigue syndrome was that it was 6 months of unexplained fatigue, and that was chronic fatigue syndrome. So you didn't have to have any other symptoms. So yes, in that sense, that's what they did. And I think probably they see a lot of fatigue patients in their clinics and diagnose them as having chronic fatigue syndrome, and actually they have anxiety and depression disorders, and they see them getting better. I mean, that's my speculation. I have no idea, but that's why I've tried to sort of understand why they think this way, and that's probably why, or that may be why they have come to the conclusion that these things work in their clinics. But in the study, it's all bogus. So they said it didn't matter that people were recovered on key variables at baseline because we had other recovery measures as well. This is absolutely ridiculous. What they're saying there is that to be fully recovered in the trial, they had 4 different criteria. And the physical function score that we just talked about was only one of the criteria. So they said, well, it doesn't matter that people were recovered on that at baseline because we had some other criteria too. But that's just bullshit. You can't have anybody recovered on any measures at baseline, otherwise your trial is screwed. I mean, you cannot do that. So it doesn't matter that they had other measures. That's just, and I said, this is bonkers. I mean, I've never heard anybody say something like that. And I've asked them multiple times, can you please show me another trial? And I've asked the Richard Horton, the Lancet editor as well, can you show me another trial in which patients were recovered at baseline on a key measure? There is no, I mean, it doesn't exist. And if it does exist, it shouldn't exist. So no one's ever pointed out to me another trial with this particular weird paradox and anomaly. So they did not obtain informed consent. this is a particular thing. It doesn't really affect the results they reported, but it's really a disgraceful thing that they did. So the Declaration of Helsinki was developed, I don't know, the 50s, 60s, I guess, as a way to protect human subjects of research. It was deemed to be important after World War II and after the experiments that the Nazis did on people, that there be some protocol about what's required. What are you required to tell human subjects of research? So the Declaration of Helsinki, at the time that they did their consent forms in 2005, said researchers must tell prospective participants about any possible conflicts of interest and institutional affiliations. Any possible conflicts of interest is quite broad. That's why I've told you about my potential conflicts of interest, which are the people who donate to me. So that is a conflict of interest. I mean, it's something that I really need to disclose. So their conflicts were that the PACE principal investigators have advised disability insurers that these rehabilitative therapies are indicated for ME-CFS claimants and that will get them back to work, even though there was no evidence for that claim. They just thought that. And they did not include these disclosures in their consent forms, even though they were required to do it under the Declaration of Helsinki, which they mentioned specifically in their protocol. So how did they answer these? We told the journals about our possible conflicts of interest, which is true. In the journal disclosures, they disclosed their possible conflicts of interest. The problem is that the Declaration of Helsinki was not written to protect journal editors or journal readers. It was written to protect the subjects of the research. It's not a response to the lack of informed consent of patients that you told the journal editors. That's just bogus. They also said insurance companies were not involved in the study. Again, this is a complete non-response because everybody knows that conflicts of interest are much broader, I mean, it's a much broader category than just who funded the study. They're getting, either they have close relationships with insurance companies and they're advising them about these therapies even as they're studying them and making claims that are not borne out by the actual research. That's a real problem. It doesn't matter whether the insurance companies funded the study or not. And they said only 3 of 19 investigators did work for insurance companies. I don't understand why they think this is a response to anything. What does that have to do with whether those 3 should disclose their ties? It makes no sense. All of these things are after the fact justifications for terrible things that they did. The participant newsletter. This was really shocking. These were some of the statements that they said. They had testimonials from participants who completed the trial. And remember, this is during the study. So they're putting out information from patients who were in the trial about how fantastic the trial was and how the therapy was excellent. This has helped me tremendously, the treatment. I found it, I'm so happy, greatly changed my sleeping. The newsletter also mentioned that NICE guidelines in 2007, which came out during the study, recommend CBT and GET based on the best available evidence. You cannot tell your participants these things. They may find it out on themselves, but you can't actively be telling them that your therapies are great when you're actually studying whether the therapies work. It's absolutely ridiculous. I could say much more forcefully these things in language that I normally would use, but I'm trying to be have a modicum of respectability here in my language. So how did they answer this? The treatment arms were not mentioned in testimonials, so there could have been no bias. It's ridiculous. You can't bias everybody. They're saying that it's okay because everybody was biased altogether. It doesn't matter. You can't do this at all. You can't bias everybody in the same direction. So they're saying that we can say these things are great, but since we didn't identify the therapies, it doesn't matter. Again, that's bullshit. People could tell that these were the active parts, not the nobody from the control group presumably was saying how great things went. They said it did not mention just CBT, but activity management, which was the third treatment offered in PACE. Activity management was not the third treatment. Adaptive pacing therapy was, and so this is just a lie. As I said, the third arm in PACE was not activity management, so that was a problem. And I ran this by a colleague of mine who's a biostatistician at Berkeley, and he looked at the newsletter and he was like, he couldn't really understand. And he said, they published this during the trial? And I said, yeah. He said, well, I guess there's really no prohibition against publishing a newsletter with testimonials because it probably never occurred to anybody that any researcher would try such a stunt. So this was the official response from my Berkeley colleague. So let's look at the objective findings. They had four. The 6-minute walking test that we talked about, the step test that I mentioned, whether people were employed or not employed, and the receipt of benefits. These results were null, which means no statistically significant, or in the case of the walking test, they had marginal benefits for the graded exercise therapy groups, but as I said, they were statistically significant, so they walked, I don't know how much, or some meters longer, but they were clinically meaningless because basically these people were still severely disabled and did much worse on the 6-minute walking test than people with major illnesses, even those who marginally did better. So these were findings that were statistically significant but clinically meaningless. The PACE team, when pressed on these things, they said, well, they came up with reasons why all their objective measures, or why 3 of their objective measures anyway, were not objective after all, even though they were the objective measures they themselves had selected. No one forced them to pick these objective measures. They said we did the walking test differently because we were concerned about people. We didn't encourage them to walk as fast as they could. They also said the room, they only had 10 meters, and normally it's done with a 30-meter room, and I mean all sorts of reasons that, okay, you picked it. Don't come up with excuses afterwards. You can't do that. Other factors influence employment benefits, etc., receipt of benefits. Of course that's true. But again, nobody forced you to pick these. You can't pick objective measures and then decide after the fact that they're not objective after all. That's not science, that's just propaganda. As I say, if subjective and objective outcomes conflict, honest researchers question their assumptions, while those without integrity, which I include all of the ones involved in the PACE trial, dismiss bad results as flawed. So they dismiss their unhelpful objective findings as flawed, or their useless, or not their objective findings, which found no benefit or very little benefit. They rejected them as flawed, even though they were their own objective measures. So is this an example of research misconduct? Yes, I would say so, because these are definitions of research misconduct that really clearly suggest that misrepresentation of data, which they did. For example, suppression of relevant findings and/or data, or knowingly, recklessly, or by gross negligence presenting a flawed interpretation of data. Absolutely, that's what they did. And that's the Medical Research Council in the UK, which funded the study, largely funded the study. Misrepresentation of interest, including failure to declare material interest either of the researcher or of the funders of the research. They exactly did this, not in the studies themselves, because when they published the studies, they acknowledged their conflicts, but not to the patients. Falsification. This is from the NIH, National Institutes of Health in the US. It's essentially the same, omitting data or results such that the research is not accurately represented in the research record. The PACE is not accurately represented because of the way they manipulated their data. Okay, so these are the conclusions. The results can't be taken at face value, and they essentially proved that treatments in this definitive trial didn't work because the findings were so marginal. I should have included here a slide about a reanalysis that was done that Tom Kinland of the ME Association was a co-author of, as was I. Carolyn Wilshire, a New Zealand, a researcher in New Zealand, was the lead author on that. So the data were released that they didn't want to release. Queen Mary University of London did release the data after being forced by a tribunal, and reanalyses showed what patients and I had reported, which is that basically they had they manipulated everything, and that they really had no findings to speak of, and that all their reports were just manipulations of data to try to make everything look better. So this is definitely research misconduct. They have no legitimate defenses, and they've always accused patients of being like climate change deniers, but from my perspective, they're the climate change deniers because they're the anti-science crowd. They're basically not doing science, they're doing anti-science. So anyway, it's just still a problem because experts all around Europe, and some in the US, but mainly in the UK, here, in Scandinavia, a lot of countries, they're committed members of what they call the biopsychosocial ideological, what I call the biopsychosocial ideological brigades. They call themselves biopsychosocial model or investigators. The problem is they basically focus just on psychosocial and not on the bio. They forget the bio and they make it all psychosocial. And so PACE is one of multiple biopsychosocial trials for medically unexplained symptoms. CBT for functional cognitive disorder. I'm going to talk about the CODES trial, which is for psychogenic non-epileptic seizures. There was a big trial of CBT for irritable bowel syndrome. I'm not going to talk about here, but that also had the same sorts of shenanigans. CBT and exercise for long COVID, so I will talk about that. And any kind of MUS, whatever it is, someone's looking at anything that they define as medically unexplained symptoms. I'm sure somebody's doing biopsychosocial research. Okay, so let's look at the, everybody with me so far? Yeah, okay. So this is a long COVID study that was published earlier this year. Clinical effectiveness of an online supervised group physical and mental health rehabilitation program for adults with post-COVID-19 condition. So basically, this has a lot of the same problems, but it reported, the conclusions were that this intervention was helpful for the patients. And it got published, and it got a lot of good press. This one takes the findings at face value. This is in Stats. That's a very well-respected publication. I was surprised to see they took this at face value when the study's really bullshit. Adam Gaffney is a pulmonologist at Harvard, so he's a very big supporter of the biopsychosocial approach, and he, again, touted this, said this exercise-based physical and mental health rehabilitation program improved outcomes. So did it really find this? Let's see. So first of all, this was a 1.2 million pound study, so that's a lot of money that went on something, again, unblinded and relying solely on subjective outcomes. So before any money spent, we can predict this study is going to find marginally positive benefits for the intervention. That's what they're going to report, because it's an unblinded study, so half randomized to usual care, so they got one session with a doctor. The others got up to, got the regain intervention, and it was 8 weeks and weekly meetings and group meetings and talking to the therapist, and so a lot of emotional jujus you get from that, right? A lot of benefits from all this attention compared to those who only got one. So it's a completely unfair comparison. The primary outcome, it suffices to say that the primary outcome was subjective and was a composite measure based on depression, sub-measures for depression, fatigue, sleep disturbances, pain, interference, physical function, social roles, activity, and cognitive function. All these were subjective scales. They massaged them all together, and this PROP R score was kind of the cumulative accounting of all these different subscales. So, are we surprised? Those receiving the intervention reported that they felt better, at least somewhat better, more than those who didn't get the intervention. At 3 months, the difference between the means of the PROP scores in the two arms was 0.03. So that means when they added everything together and they did the averages, those in the intervention group had a score on this measure that was 0.03 greater than the other score. So why is this a problem? Many measures have something called the MCID, which is the minimal clinically important difference. In other words, this goes back to what I was talking about statistical significance versus clinical significance. You might have a benefit of 0.02, right? But they've determined, but like say they sort of do through statistics and stuff, they come up with a figure that they consider the MCID. So when this study was started, this was true, what it says in the method section. Method section claims difference of 0.03 to 0.05 is considered to be clinically important for PROP R. However, when you look at the reference that they cite for that claim, you see that it undermines the claim. Because what's happened since the trial was started, there's been those who developed this measure in the first place were reanalyzing what should the MCID be, what should be considered the minimal and clinically important difference. And they determined that it should be 0.04, not 0.03 to 0.05. So they narrowed the threshold a bit. Now, they say this is recommended. It's not completely like a ratified thing, but this is the recommendation. And that's what's in the reference that is cited for this. but the reference contradicts it because the reference says, no, this is the recommended now. So the study mentions this switch deep in the text, not in the method section up high, but only when you get to the fine print down below. And they say, the text itself contradicts what is claimed in the method section. In other words, it's a lie. They lied in the method section about the reference, and they lied in the method section about what is considered the current MCID. They might have mounted an argument saying, we don't agree with this MCID, but you can't sort of say one thing there and then something else later in the paper. And the findings in any event are so minuscule. Even if 0.03 was the MCID, it's such a minuscule finding that it's easily explainable by the bias that we've talked about from the study design, because they had no objective measures at all. And so one of the facts here is, maybe an 8-week online Harry Potter book club or a French cooking class on making the perfect crepe Suzette would have produced the same results. We just don't know, right? Because you're giving people all these attention, they're going to feel better. So we don't know what the active ingredient is. It could easily be just the attention when you have such minimal findings. The other thing is that only 47% actually completed the full program, and a significant number didn't take it at all. So that's a real problem when you have so poor adherence to your thing. You have to wonder, why was the program not helpful for those people? Why did they stop going? So the other problem was that Regain was extrapolated to all long COVID patients. So, or all what they call their definition of post-COVID condition. But the problem is, this cohort of patients had all been in the hospital. They were all hospitalized because of their COVID. Patients who are hospitalized have very different presentations and very different issues than those who are not hospitalized. 90% or more, or I don't know what the exact number is, but the vast majority of people who report long COVID symptoms were not hospitalized. You cannot extrapolate findings from hospitalized patients to a broader population. That was one of the problems I cited in the beginning, that who you study and who you extrapolate to are they have to be parallel. You can't study women and then apply it to men. You can't study infants and apply it to senior people. You have to actually study the people that you want to extrapolate to. In key sections, the abstract and what this study adds. What this study adds is often a box or new elements. It's sort of a box that they put next to the study, sort of like a shorthand, so people can look at that and don't even have to read the study, right? Because they can see a shorthand of that. Excuse me. So the key places where people will look and maybe not read the whole study, the abstract. If that's my mother, I'm not here. And what this study adds, they didn't mention this distinction, which is a critical distinction for understanding the study. As I said, it's absolutely disgraceful and absolutely incomprehensible oversight. The paper has now been formally corrected a few months later, after they were like, they seemed to be upset about all the criticism, but they finally did correct the paper. And they added in key sections at least 3 months after hospital discharge for COVID-19. So they did add to those sections what they had left out. And it's hard to sort of see how researchers and peer reviewers would overlook this. I mean, either it's by mistake or it's intentional. You have to be incredibly incompetent to have done it by mistake. So either the researchers are all, and this was a very, very big research team, lots of people, distinguished people, presumably, and the peer reviewers also had to be completely incompetent not to see this distinction. It's very clear. You cannot make this extrapolation. And the media, of course, when the study came out, the ones that I posted, and many, many other media outlets or commentators, they highlighted the original claims. They didn't point out that this only applied to hospitalized patients. So I didn't see any media coverage of the correction. This happens all the time. The study comes out, it's flawed, blah, blah, blah. It's corrected, nobody sees the corrections because it's published, who cares, right? So that's what happened with this study. So I organized a letter. One of the things I do is, as I said, arrange irritating letters. we were seeking a correction. I focused in this one just on the minimal clinically important difference and not on the false extrapolation, because I figured you sort of need to focus on one thing it's often best to focus on one thing just to make a hard point. And I got, as I tend to do, I get a lot of colleagues to re-sign the letter. So we signed it, but they didn't correct the part that we wanted them to correct. So now we're going on to functional neurological disorder. So as many of you may know, there's many, many forms of FND. Basically, again, it's seizures, though, is one of the classic areas where an FND diagnosis is given. Traditionally, these have been called psychogenic non-epileptic seizures. Now they call them dissociative seizures as a way to kind of reduce the stigma of calling something psychogenic, but it essentially means the same thing, or psychosomatic. And so basically, since at least 10 years before so often when you do a study, a big study like this with many, many people, you've done pilot studies. This is based on a pilot study done many years before, and they've spent a lot of years defending seizure reduction at the end as the primary outcome. Of course, if you have these seizures, you don't want to have seizures anymore, so of course seizure reduction is an appropriate primary outcome. So what happened in this study? With the intervention, this had 368 participants. That's a very large study, all with seizures, presumed PNES, psychogenic non-epileptic seizures. And the intervention was a specific form of CBT for seizure reduction. So that's what they do all the time. They say that this is specifically targeting the factors that we believe cause these seizures. And so it's designed specifically to target the seizures. So what happened? At 12 months, the non-intervention group had more reduction of their seizures than the intervention group. So not the kind of finding that you want in your study if you're trying to prove that this works, right? But they also did something weird. They had 16 what I call squishy secondary outcome. Again, these are how do you feel, all very generic, depression, anxiety, all sorts of other things. But all secondary outcomes. In their initial results, 9 of those were positive. Now, there's something called correction for multiple tests or adjustment for multiple tests, which is when you have a bazillion or 16 different things that you're looking at, just by random chance, something's gonna may be positive that doesn't have anything to do with actual findings. So what you're supposed to do when you have multiple tests, or what you can do, is that you do a statistical adjustment to take into account that you might find something by chance. So when you do a strict statistical adjustment, only 5 of these 16 survived that. So after they claim 9 were positive, but only about half of those, after they use a more stringent way to assess them, only 5 of them were positive. So their conclusion was not that this didn't work, but that seizure reduction is not the best primary outcome. Huh? Why is that? Why would they say that? Well, they said that because they got some squishy positive results on people felt more socially this or that or whatever, and they decided that therefore seizure reduction was not that important and we're focusing on the wrong thing. That's a completely self-serving interpretation. I think we can probably all agree. Quality of life measures were more important than actual seizure reduction. I don't know if they asked patients this, but this is what they concluded. And the press release from King's College London, which was the lead institution involved, basically was completely deceptive. It said CBT reduces the impact of dissociative seizures. Well, the main result of this study was primary outcome fails. Primary outcome had no results. CBT did not reduce number of seizures. That's the primary outcome. That's what you have to put at the head of your press release. The press release is supposed to actually accurately frame the findings. It's not supposed to manipulate and obfuscate by saying bullshit like this. Trudy Chalder, who I've had experience with because she was a PACE author, and she was also the senior author of Codes, we now have evidence for the effectiveness of dissociative seizure-specific CBT combined with standardized medical care. But effectiveness for what? It had no effect in reducing seizures, and in fact, the other people who didn't get the intervention had more seizure reduction. Now, I will point out that the control arm had greater seizure reduction in an absolute sense, but it wasn't statistically significant. So it's not really a finding. It's just that it trended that way in the absolute numbers, but it wasn't a statistically significant finding. But nonetheless, it's not a good finding for your study. And even though the press release acknowledged, again, down lower in the press release, that there was no clear differences between the groups in seizure reduction, it did not mention that this was the primary outcome. Is the press release fraudulent? Absolutely yes. So at the same time, as I mentioned, one of the ways to manipulate or to get the word out the way you want to is to have a friendly commentary by a colleague in the same journal. So what did they do? Also in Lancet Psychiatry, David Perez, who's at Harvard Medical School, who's also a big FND guy, neurologist, he had a commentary. So here's what he wrote. In my opinion, CBT remains an effective treatment for dissociative seizures. I have witnessed how some patients with dissociative seizures, blah, blah, blah. This is all well and good, but the study doesn't care. We don't care about his personal opinion as a clinician. That's not the point of the study. Clinicians have personal opinions all the time. We don't rely on their personal opinions all the time because we have studies that may show the opposite. It's fine for him to say he has patience, but we have no evidence of that. The study doesn't say what he says. The study says it didn't work. Again, he repeats the same thing. A major question is whether seizure frequency should be the preferred primary outcome measure in clinical trials. The only reason that's a question is because it didn't work. Right? That's the only reason they have a question. They want to come up with the one that did work, which is their sort of squishy secondary outcomes and not seizure reduction. So this is completely self-serving. Then he suggested that other psychotherapeutic interventions should be tried. Based on what? They already did this. This is supposed to be seizure-specific CBT. If that didn't work, why is he proposing other things rather than reassessing whether this is really the right approach? In a more recent paper, this codes was from a couple of years ago, but a more recent sort of reflections on codes basically basically blamed the funders for insisting on seizure reduction as the primary outcome. And I'm like, wait a minute, you guys have been arguing for more than 10 years that this is the right primary outcome in previous papers. And they've defended this as the primary outcome from previous challenges. So why are you now blaming the funders? Probably the funders, or maybe the funders, picked this up from your earlier research, and that's why they insisted on it. You can't then go back when you've claimed this is the primary outcome and then blame the funders for picking it. It's just complete nonsense. You can tell I'm just fed up with these people. So this is kind of in conclusion, since this was talking about how these harm patients. So do these harm patients? Obviously, yes. They lead to unhelpful therapies, right? Because CBT and GET are not helpful therapies if you have post-exertional malaise. CBT may be helpful for supportive care, but not to cure your ME. So they also, the idea that you don't want to sort of encourage patients in their thinking by doing too many tests is another side effect of these sorts of studies. It discourages clinicians from actually doing real in-depth investigations that they should do. Patients often feel dismissed and gaslighted by these claims because they know that they say, well, you have to do more, and they say, well, I've tried and I get worse. Well, no, that's because of your thinking is problematic and you have to, all this kind of stuff. So patients feel like crap often from these. And then, of course, it diverts resources away from biomedical research because basically so much of the research, say, especially for chronic fatigue syndrome, has been devoted to this nonsense theorizing and to studying CBT and GET in all sorts of different ways. And the PACE trial itself was a £5 million trial. So how much of that money could have been spent on actual biomedical research that might have actually helped patients? So yes, it does harm patients. I'd be remiss if I didn't mention that I'm crowdfund for my position, and I'm currently crowdfunding. October's a crowdfunding month at UC Berkeley. I crowdfund twice a year. So this is the status of my crowdfunding as of earlier today. And so these are my thanks. Basically, I want to make sure that I say that pretty much patients had done a lot of this work before, and I've really relied heavily on patient input. And those of you who might have seen my initial PACE investigation will know that a lot of it featured Tom Kinlan, because he helped guide me through the research, who is now here. So I want to thank him for that. So I've been on this journey with him a little bit for the last 10, well, we contacted him 10 years ago. Professor Racaniello at Columbia, who basically trusted my reporting and gave me free rein to post whatever I wanted on his blog. I had complaints to UC Berkeley trying to sanction me, mainly from the University of Bristol, where Professor Esther Crawley was. And Berkeley got complaints about my behavior, and they said, well, what does your behavior have to do with it? Are they saying, they didn't say I did anything wrong, they didn't say I did anything inaccurate, they just didn't like my behavior, which basically consisted of harsh criticism of one of their researchers. So Berkeley thought that this was ridiculous and just didn't respond, basically, ignored it. This is my home institution at Berkeley, the Center for Global Public Health, and my faculty colleagues at School of Public Health and biostats at Berkeley have been very encouraging, have always supported my work, even when I've come up against these criticisms. And many people, many academics and others sign my open letters, that I've written quite a few, and so I want to thank them as well. And so that's my talk. Thank you. So I can answer any questions, or if anybody has any questions, or whatever. Yeah.
I'm not sure if this is quite a question, but I also wanted to say that as a student, as psychologist of psychology, I do feel that the biopsychosocial approach really puts too much emphasis only on the psychosocial and not enough on the bio, because they're all connected. Of course, if somebody's very ill, it may make their mental health worse, but at the same time, I also felt and experienced that just therapy will not make the ME go away, like these chronic fatigue syndrome go away. I also experienced that, and I also found that a lot of the studies that I read also suffered from the same flaws that you pointed out, just like, oh, it must be that they're thinking bad.
Well, I think it's a very important point, because I'm in public health, and the first thing you learn as a public health student is about the social determinants of health, which is essentially, on a public health scale, the same concept as biopsychosocial. It is self-evident that our environment affects us, that other people's influence affects us, that how we feel affects us, that depression and anxiety can trigger panic attacks or other things. So nobody disputes that. The question is, what is at the root of these things? And is it really depression and anxiety, or is that you have inflammation in the brain, or you have inflammation in your body, or you have cytokines that are going out of control, or other things going on? The problem with the problem isn't the biopsychosocial model per se, it's that, as you say, they ignore all the bio and they focus just on the psychosocial. And so that's the real problem.
Especially with the CBT, because it puts so much emphasis on thinking the right thoughts and avoiding thought fallacies.
Right.
And it blames a lot of so-called blame on the individual. Oh, you didn't phrase your thought right.
Yeah.
Well, this relates partly to the issue of association and causation. So they do studies. One study recently about long COVID. It was a cross-sectional study, which means you're taking data at one point in time. So, so often you might find data at one point in time. You might find that those who are sicker are more likely to believe, this is sort of something that these people do, they find that those who remain sicker are those people believe that their illness is physically based and not psychological. So from that they decide, oh, the reason they're not better is because they've decided that their illness is physical, when the relationship is probably the other way. The reason they decided that their illness is physical is because whatever they do, they're not getting better. You can't make the argument this way when the plausible argument is just as well going that way. And so when you have a cross-sectional study, for example, like a good example is like HIV, and for example, gay men, they was found in a cross-sectional study that gay men who practiced unprotected sex were more likely to have HIV. Now, one conclusion, which is reasonable, is that gay men have unprotected sex and then they get HIV. But the other conclusion, equally plausible, is that gay men who have HIV are more likely to have unprotected sex because they can't get HIV a second time. So you can't take a study like that with data from one point in time or data that's an association and correlation and decide that the causation goes in one direction of your preference. We don't know. Those studies don't tell us which direction causation is going in. So they might say, well, it doesn't contradict this, but it also doesn't contradict that. But they uniformly take associations and place causal value on them, and you can't do that. It's just not right. Depending if you're doing it intentionally, it's research misconduct. If you're doing it because you're stupid, it's just incompetence.
Yeah, I think they lost the fact when it comes to therapy. Like, I'm a qualified humanistic therapist, but I haven't practiced in a long time, and I was sent to CBT when I was diagnosed. And like I was saying earlier, I was sent to 5 different consultants before I got the diagnosis of MS. And the reason I was sent to all of these different consultants was because fatigue, it's a huge part of a lot of different illnesses.
Right.
It's a symptom. So they weren't sure what was going on with me, but when they cleared one, I was sent to another and another. This went on for 2.5 years. And then when the last one was the immunologist, and she sent me to a psychologist. And even my psychologist said, so they told you that your body is failing, so they decided to send you to a head shrink.
Mm-hmm.
Like he even saw the stupidness of it. And he even, like my therapist, like she even said, you understand, said, I can't think that I'm not well. Like, you know, if I'm tired, I'm tired. Me thinking I'm not going to be tired isn't going to change the fact that I'm tired. You know, so, but you are right, because CBT sometimes can make the person feel that you're not doing enough to make yourself. So it can be damaging that way. Instead of helping the patient, you know, look at that, how can they manage the illness? Then tell them that they're ill. So there's a huge difference in how you do your CBT.
Well, one of the issues that's very frustrating is that these people routinely say, well, I don't know why you're complaining, because, you know, CBT is used for cancer, it's used for this, it's used in that. Of course it is, but nobody's saying it's curing your cancer. Nobody's saying it's curing your MS. It's there strictly to help you cope with the problems, and that's appropriate. That's appropriate for ME as well and for long COVID. It's supportive therapy. It's not curative therapy. You know, whereas if you have depression or you have anxiety,
but depression goes with chronic illnesses, because you are going to be depressed.
Of course.
Your life is completely changed, and for the first time in your life, you don't have choices that you thought that you had, and that, you know, it's so many is taken away. So of course you're going to be depressed.
Well,
so it is important that you do have both to help you through and give you tools first.
And this is another conflation that they often make, because when they find an association, of course there's higher levels of depression, anxiety, and all those things among chronically ill patients. When these people find this, they make it an argument that, or they present the argument as if they've sort of proven that the anxiety and depression anteceded the illness, when, you know, in most cases it's perfectly rational and reasonable and understandable that if people have an illness that nobody understands, that they aren't getting treatment for, that people misunderstand, they're going to have more anxiety and depression. It's human nature. So, what I don't understand is what seems to me a willful misinterpretation of findings just to conform to their prejudices and their biases. And this is constantly, I've been doing this so long, I thought I would, I didn't intend to spend most of my 60s doing this work. But it's just that it goes on and on and on. And then I was thinking of ending my project, but then when long COVID happened, I saw the exact same cohort of people and the exact same sort of denialists, and ideologues imposing the exact same framework on long COVID. And what I don't understand, ME-CFS happens sometimes, we've seen epidemically, but mostly it happens sporadically. So someone gets sick and that person, doesn't get better. So I can understand if clinicians see individual people occasionally, they might have that idea. But what we're seeing with long COVID is a worldwide phenomenon, or what we call a natural scientific experiment, an unfortunate natural scientific experiment, where millions of people around the world are reporting the same things, at the same time. We have millions of people with COVID, and then millions of those, whatever percentage, 5, 10, 15, 20, whatever percentage, and how you measure the symptoms and how you assess it is going to give you a different percentage, but some percentage are remaining chronically ill. And so you can either, if you see that phenomenon, you can either decide, gee, there's mass hysteria and all these people are being told by the ME groups that they have ME, or that they have this, and that's why they're all sort of persuading themselves that they have this incredibly debilitating illness. Or you can think, gee, there must be something really going on with people's bodies here with this chronic reaction to the virus, whether there's continuing virus or whether the virus has been eradicated, but there's immunological factors, that something's going on with all these people, that everybody in every country is reporting this. It's not like most of the people who have these things know about ME and know that there's some people who get ME after an illness. No, people don't know that. People aren't being influenced by, they are being, obviously people are influenced by what they're told, but the idea, George Monbiot, who's a well-known columnist for The Guardian, had a bout of long COVID that lasted a few months, and he wrote about it. And Michael Sharp, one of the PACE investigators, then in a presentation for an insurance company, of course for an insurance company, because that's what they do, basically blamed George Monbiot for spreading long COVID because she wrote about it. So other people will get the idea from that, oh, I have a twinge here, and oh, it must be long COVID. The idea that millions of people around the world want nothing better than to lie in bed and be sick and fulfill their sick role to get some sort of psychological benefits, or, they've sort of separated it from what they call malingering. But the idea is that people fulfill their sick role and get lots of psychological benefits from the attention and all this stuff. The idea that millions of people around the world want to actually destroy their lives by pretending or by thinking themselves into having an illness that they can't get out of bed when formerly they were a hardworking doctor or lawyer or writer or actor, I don't know why people would think that, but that's the way these people are thinking. And, to me it just is preposterous on its face.
The HPV vaccine has contributed. The HPV vaccine has contributed to young people getting ME.
Well, yeah, it's hard to tell. A lot of reports of post, vaccine, and also a lot of questions sometimes about the long COVID vaccine. The COVID vaccines, whether they may be triggering in some people cases of long COVID. I think a lot of the stuff we still don't really know, and it's just being figured out.
Are you aware of any positive trials or any promising treatments or anything?
So, there's studies of various things going on. I tend not to talk about medical treatments as much, since I'm not a doctor and I don't want anybody to take anything I say as medical advice. So I've been more in the business of pointing out what I think is bullshit than saying what I think it is, because I don't really have a good basis for making determinations. But there are studies going on, and there's a lot of research going on into what are the sequelae of long COVID and why are these things happening. So, part of the problem is figuring out what are the mechanisms that are causing this and then finding ways to target those mechanisms. And so that work is being done, not as much as one would hope. There's still too much money being spent on this kind of crap. Again, like I say, you don't need to spend £1.2 million to know that if you give people an intervention, and other people you don't give an intervention, you're going to have marginally positive benefits reported. So that's what they found. I could have told them that before, and I did. I rember in the protocol for this study, I said, this is what they're going to find, and they did. So, part of the problem is just the waste going on, and then the money not being spent, being diverted from other research into this kind of research. So I didn't really answer your question. but I'm not completely qualified to answer your question. So I mean, there are, there's people looking at all the various immunological factors and what are the compounds that could, mitigate those. But I'm not really prepared to talk about them.
Why do you think the medical...
I'm a little hard of hearing, that's where I'm coming
Why
from.
do you think the medical profession have allowed this to be gaslit for so long, like being taken up by the psychologist?
Well,
When there's actually, you know that there's, like, it's an autoimmune type of illness. So why has they allowed it to go on for this long? Like, this isn't a new illness. You know, we've all read up on it. It's gone back 50, 60, 70 years. So why is it still being gaslit?
well, so there's a number of reasons. First of all, doctors generally, as I said, these are called heart sink patients, right? Doctors don't really know how to deal with these patients. And doctors tend to not necessarily want to admit that they don't know something. And patients want answers. So doctors understandably want to give patients answers, and they don't want to say, you have something, it's terrible, we really just don't know. But that's the answer. The answer isn't, it's functional. The answer is we don't know what it is. We don't know why. We're trying to find out. These are some things that may help. These are some things that can treat symptoms. So I think there's a sort of built-in human psychology aspect that, doctors want to give answers and patients want to get answers. And patients probably don't want to hear, I don't know, but they probably would rather hear, I don't know, than an answer that's not really based on the science. The other thing is that it's very advantageous for the people that these people consult with, government agencies and disability insurance companies or health insurance companies, to not have to pay for expensive treatments or long-term disability. An insurance company doesn't want to pay people for 5 years for not being able to work if they're told, hey, 3 months of CBT should make this person better, and if they're not better, it's their fault anyway. That they should get better from this, and if they don't, then too bad for them. So that's kind of what happens. So it's advantageous to governments because they spend less money. The NHS is broke. They don't want to deal with all these patients. Insurance companies don't want to pay out benefits if they can finagle away, is that a word here? Yeah. Finagle away to get out of paying benefits. So there's a sort of a nexus of interests between the researchers who promote this stuff, the government agencies that fund it, the NHS, the insurance companies that are in the business of not paying out money. And there's evidence of Peter White, the lead author of the PACE trial, has written notes. This person didn't get CBT or GET. I mean, I've seen one note of he didn't get CBT, GET, shouldn't get benefits until goes through a course of therapy. So that's part of the incentive. And I think a lot of it for the people involved who have been promoting this stuff for 30 years or whatever, Simon Wesley, Michael Sharp. I'm 68, so if you told me that the last 40 years of my life, what I was doing was not only stupid and incompetent, but actually harmful to people, well, I don't know how I'd react. It's very hard to think that your entire life has been involved in bullshit, but that's essentially what I'm saying to these people, that this is all bullshit research, and that's what you've been involved with for 30 years, and your work has harmed people. So that's not really a message that anybody wants to hear, and I think it must be very, very difficult to hear, obviously. And they reject it completely. And so, we're sort of involved in, I think, a paradigm shift of what we consider to be post-viral illness. Is it sort of the or post-acute viral illness? Is it sort of a psychological, functional state that we don't, whatever's going on? Or is there something really going on with people that we have to look at? And, they say paradigms don't shift. What do they say? Paradigms shift one death at a time. When the old people die off, new people come up, and it's not, you don't change people's minds. You just they get moved aside as they age and move on, move over, and younger people coming up do better stuff, or new situations change things like long COVID. I think many people look at long COVID and say, gee, we've been wrong. It's really brought a lot more attention to this whole realm of post-acute infectious syndromes. So there's a lot more talk now, for example, in the US of funding at the NIH, trying to set up an institute. The National Institutes of Health has multiple I don't know how many, a dozen or more institutes in different domains. So there's talk about setting one up specifically to study post-infectious, post-acute infection syndromes, or post-viral syndromes as they've often been called. The thing with post-viral suggests that that the virus is gone. So we don't really know, so that's where they've sort of changed to post-acute infectious syndrome. So it leaves it ambiguous as to whether the pathogen is still there or not. But I think this phenomenon is forcing a paradigm shift, or is sort of creating a greater impetus for paradigm shift in this whole domain. And creating awareness, it's always been known that epidemics leave some people with permanent illness. After the Spanish flu, there were a lot of reports of people with prolonged symptoms. There have been lots of studies done that show every pathogen generally, especially viruses, leave a certain number of people with chronic conditions. It's not a secret. So this is just bringing that to sort of worldwide attention and making, doctors weren't aware of this. At the beginning of COVID, of the coronavirus pandemic, March or April or May of 2020, was it 2020? It's hard to remember now. 2020, everybody in ME world was writing or saying, after this, we're going to have a wave of people with unexplained symptoms, and they're going to be told that it's psychiatric or psychological. It was predictable, and that's exactly what's happened. So this is not a surprise. We know this. We know that this is a phenomenon, and the problem is we haven't spent any time trying to deal with it, because all we've spent in the last 30 years is looking at biopsychosocial stuff. And maybe if we'd spent 30 years, instead of being diverted that way into looking at what's really going on with people, we might have had a different, we might be better prepared for long COVID now. The problem is that, again, because most people with ME or CFS or ME-CFS, whatever one wants to call this cluster, are diagnosed years later. The fact that it was after a viral infection or after whatever is just self-report, right? Not that you don't trust people, but people's memories are imperfect. Maybe it was related to that, maybe not, maybe, we don't really know. With something like long COVID, we have a direct connection. Pathogen, infection, illness. So it's easier in a way to use this phenomenon now to track what's going on. And to say, at least when it comes to coronavirus, here's what seems to be happening that seems to be related to these prolonged effects. Now, that doesn't mean the same thing exactly happens with Epstein-Barr virus or with whatever enterovirus or whatever other virus may have triggered someone's ME, but at least it gives a model or a way to start looking at these things with a known pathogen and identifiable mechanisms that are going on. So I think we are in a different environment. The problem is research takes a long time, and it takes money, and it takes smart people. And these people may be smart, but they're also stupid because they're doing really stupid things. So I can't say when there will be answers, but there is research going on, and I think there is a change in awareness among many people in infectious disease world and researchers that this is a real phenomenon we have to deal with now, whereas before I think it was really kind of dismissed, or was much easier to dismiss. These people seem able to dismiss the fact that so many people are disabled by saying it's functional, or it's psychological. But I don't think in the long term that is going to be an effective strategy. It's not going to be a convincing strategy. I know it's not an effective strategy. I don't think it will be a convincing strategy ultimately with so many people sick.
I also think the problem with specifically using CBT as the therapy is because when I read up on criticisms of CBT in my psychology studies, a lot of it is, why do patients not benefit? The patient didn't put in enough work. So if we put CBT as a curative treatment for these whole cluster of illnesses, it's going to be like, well, why did the patient not recover from their symptoms? It's because they didn't want to recover, it's because they didn't put enough work into the therapy, it's because they didn't make enough positive lifestyle changes, like enough exercise or enough sleep.
Right, and I think it does lend itself to that in these kinds of contexts. It doesn't lend itself to that if it's used as supportive therapy to help you deal with your anxiety, depression, all the things that accompany the illness. But of course, if it's used and it's proclaimed to be CBT specific seizure reduction, specific for seizure reduction, well, if it didn't work for seizure reduction, it must be your fault, right? I mean, if it's specific for that and it didn't work, they're sort of saying, well, it's not the therapy. The therapy, it should have worked, and they claim the therapy works because of all these weird secondary outcomes. But yeah, you're right. I mean, it lends itself to patient blaming in that way, which is why patients feel gaslighted, and patients know that it doesn't work. Their experience is that it doesn't work. And the PACE trial proves that it doesn't work. The PACE trial, far from proving that it worked, it proved that it didn't work. If you actually look at the results that they got and not the ones that they claim to have gotten.